right, good afternoon, everyone. We're just going to give a minute for everyone to populate and get into our room today, our Zoom room. Welcome, everyone.
And I'm going to speak just briefly. If you can indicate if you can hear me or not, that would be great.
Yeah, we were having some sound issues. Everyone okay with hearing both of us? You can put a little thumbs up in your chat. If not, we might hear from them too. All right, we're going to go ahead. Oh, right. Yeah, okay, great. Thank you. Thank you for the comments. Yes, thank you very much. All right. All right, so I'm going to go ahead and get started, and Carol's going to advance the slides because she's got her intro slides on the front. So, all right, good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to today's webinar. Go ahead, next slide. So, of course, as you were brought into the webinar, we're going to use the chat function for Q&A. So if you've got any questions during, after, please go ahead and use the chat function and put your questions in there. We'll be keeping an eye on that. Your phone or your computer microphone were muted. We also have a post-webinar evaluation, which will populate when we're done. Please go ahead and fill that out. And there is CME credit for attending the live presentation. The recordings will be posted onto our website, and I will have this information in a thank you email when we are done. You don't need to worry about copying that information. So as you were registered and so you got information with the continuing medical education, the outcome objectives, accreditation statement, and disclosure, I don't need to read it. Just know that for the attendance tracking for CME credits, the code will be found in the evaluation. And if you haven't set up your profile yet in the Cloud CME account, there will be instructions in my email going out to you if you are joining us for the first time. Anyway, so we can go to the next slide. Standard disclaimer, and Carol will go over this. I think she has one of these in her own slides as well. The next slide.
I think that is my disclaimer.
That is? Okay.
We can disclaim each other.
There we go. All right, and again, be sure to check our website for upcoming webinars and events. We're working on our 2026 training and webinar schedule, so that will be added to our website. And the best way to keep in touch and find out when our events are is to sign up for our newsletters. I'll have that information in the thank you email as well. It's a quick little URL link. You can sign up for which newsletters, blogs, and event lists you would like to get in your email, and you can keep up to date with us. Right, next slide. And again, your opinion is valuable to us. This is how we help get different topics to bring to you from our audience, telling us what you'd like to hear about. Again, the evaluation link will populate in a separate URL, and I'll also post it in the chat. All right, so next slide. Without any further ado, I get to introduce Carol Yarbrough. She is our billing, compliance, and reimbursement expert. She frequently comes on and talks about everything telehealth billing and reimbursement, and she's talking about care management services. What's telehealth versus not telehealth? Carol, go ahead and take it away.
Hey, good afternoon, everybody. I'm so pleased to be here again. Thank you, Melanie, and thank you, Aref, our intrepid sound person. Let's get started. I have a ton of slides. Sorry. Okay, things to remember. The slides are going to be provided. There's a lot of information on there. And, you know, the PDF is going to be posted. If anybody wants the PowerPoint, I'm happy to share that too. Just contact Melanie and she'll forward your info to me and we'll be good. Ask questions as we go along. I'll try to answer in context. I'm going to try to keep an eye in the chat, but I usually don't. And please enjoy the next hour. You get a CME, and I'll try to keep it entertaining because, you know, that's my gift. I think that's my gift. All right. Okay, so the CME description, I didn't hold to it quite because there was so much information just about chronic care management. But I will say, okay, let me go through the agenda. Care management services, what makes them not telehealth? A policy extravaganza, which is also a CPT comparison of chronic care management, RTM, RPM, whatever, you'll see it. And then a few clinical examples at the end that you can code for yourself. Just note that as I mentioned, the CME description did state e-visits and e-consults. I have gone into e-consult maybe a bit in other contexts, especially the webinars that well, probably not me, but other people, the webinars on behavioral health. There are new e-consult codes for non-qualified healthcare providers, which is usually like a psychiatrist, a doctor, PA, NPP, a DO. There are new codes for non-them. So any questions about that, happy to answer and follow up as well. Same thing with e-visits. They're not telehealth. They're not care management either. They are asynchronous, and you can talk to a patient via a secure portal back and forth and bill for that over a series of a couple of days, and adding up the time. What makes it not telehealth, though? We'll get into that. See, I always pre-talk myself. I didn't put the hymn in there, though. All right, care management is a mixed bag of synchronous and asynchronous activities. So for care management, the initiating visit must be face-to-face, real time, or if there are technical issues, real-time audio. It can be an evaluation and management visit, annual wellness visit, welcome to Medicare visit. Can be done during a telehealth or an in-clinic visit. How many times did I just say visit? A lot. But it has to happen in the now, like right now. And during that initiating visit, the provider invites the patient to participate in a care management program. The asynchronous part, and what makes it not telehealth? Now, the synchronous visit, it's part of care management, but it's not part of the bundle that you bill. It's a separate billing episode where you consent the patient, has to occur. The rest is asynchronous. There can be some real-time conversations going on with staff and or the supervising provider of the program, the plan. But the asynchronous stuff is behind the scenes to take care of that patient's needs and keep them out of synchronous visits, because we want to keep our synchronous visits for more new patients, for acute patients. We want to manage chronic conditions asynchronously. So again, telehealth is synchronous only, and this is hard baked into the Social Security Act, Section 1834M. And they do state it means a professional consultation, office visit, and office psychiatry service. And it gives the codes that existed back in the dark ages before we had over 200. And they're on the Medicare telehealth list. Now, a very smart CMS/Medicare analyst told me it just means telehealth is on the list. Just think of it that way. And Emily, thank you so much. So if it's not on the list, it's not telehealth. Just think of it that way. So this is where you can download that telehealth service list. There are no asynchronous activities represented by the CPTs and activities on that list. It's asynchronous, either audio, video, or audio only. I'm pointing my finger at y'all, but in a good way. So the billing implications, what are the billing implications? This is what gives me, I don't know, when I talk to vendors about billing chronic care management on their own, and they're only virtual, they can't do it. Why? Because they're a telehealth company. They can only bill using place of service 02 or 10 because these are for telehealth only. chronic care management it's got to be brick and mortar. And if somewhat telehealth shaped, why not telehealth? Because it's not on the list. It's one of my favorite memes. If not friend, why friend shaped? There are things about chronic care management that are telehealth in nature just because they are technology enabled, but they're not telehealth, they're not on the list, and they're not synchronous. So just forget about those. Okay. Okay. This is a nice little chart I put together. Place of service codes. So this is what happens. You have a purely virtual company wanting to do chronic care management. But can they be in office where CCM is allowed? Yeah. It's most common. Outpatient hospital. Yes. Off-campus outpatient hospital. Yes. A SNF with some limitations. These are brick and mortar places. If you are a purely virtual person, like myself right now with you, I can't bill any of this stuff. I have to contract with the University of Arizona and the Southwest TRC to give you, I don't know, brick and mortar advice about where you can bill using a brick and mortar place of service code. Here's some other ones. Nursing facility, independent clinics, yes. I don't even know what that is. ESRD facility, conditional, yeah, sure. As long as you're not overlapping the care for dialysis, you're managing something else. Hypertension may be associated with CKD. No. O2 and 10, no. No. Home, no. I mean, a person's home is brick and mortar, no matter where they live. Well, maybe it's stucco and asbestos, depending on how old the house is. My house is over 100 years old. We took out all the stucco and asbestos. But it's not where the staff or the billing practitioner is going to be doing the service. So that's my spiel about place of service. So the chronic care management code groups, there are a lot, and they're really sorely underutilized because they're not easy. This is all not telehealth. It has virtual aspects to all of this. TCM, by far the easiest, by far. General behavioral health integration care management, the second easiest, my opinion again. PCM, third. I should have numbered it. RPM and RTM. Now, we all know this ain't easy. I keep on thinking of the George Harrison song, and you know it don't come easy because it's getting harder. CCM is not easy. Complex chronic care management. It's just as hard as chronic care management, but the risk associated with the patient's condition is higher than simple chronic care management. And then the psychiatric collaborative care management, by far, maybe because I've never done it myself, I'm just here to talk about it as if I know what I'm talking about. But it seems hard to me. And when you go to the Medicare data warehouse and look up any of these codes, not a whole lot have been billed, and there are a lot of Medicare beneficiaries. I forget the number. It's a lot. But any of these codes, if you pick like 99091, which we're going to talk about very soon, or 9909091, it's one of the chronic care management staff codes, only billed around 65,000 times in 1 year. Who does that? Probably 2 clinics have got it down and they're doing it. I hope they're doing it right. It's not easy. Okay, coverage policies. Okay, I'm going to talk about the codes and the coverage with exemplar insurance companies. So TCM. This is where you are discharged from an acute care hospital to home or to wherever, SNF, rehab. If there's moderate complexity associated with your discharge, probably this 99495 type of person is being discharged to home. I'm speaking too slow. There are a lot of slides, but I'm going to get into this because I want you guys to do this. It's lovely and it pays. I didn't put the reimbursement on this, but you can go to the CPT code lookup on the Medicare site and put in your location, your MAC, and what the CPT codes are, and find out what you're going to get paid for where you're located. It includes the gypsy information and all that. Anyway, you're supposed to have a face-to-face visit within 14 days of discharge. Now, in the halcyon days prior to October 1st, this face-to-face visit could happen via telehealth or in clinic. Currently, for people, say, in Tucson or in San Francisco, where I am, or in Phoenix, Colorado, these are heavily populated areas. Cannot do telehealth. Has to be face-to-face in person currently. We won't go into this. We've heard enough about it. If you have questions about that, I'm happy to answer that too, but not now. Not now. So anyway, within 2 days, here's the technical part. Someone can call. You have to at least leave a couple of messages if you're not making direct contact with the patient. Please call me. I need you to make an appointment within 14 days or before X whatever, October, whatever. Well, November now, because we're done with October. So it's within 14 days of discharge. It's not urgent. Now, 99496, this is maybe somebody who gets discharged to not home, or maybe home with home health care or something. So again, the synchronous activity is the telephone call, the message, or in person. Someone comes in for something else, you see them in the hall. Hey, no, I'm kidding. If you document that conversation, it works, man. If they're in the hall and you see them there for another reason, you document that, you're golden. MDM is high complexity, and that just means they got more stuff going on. You want to talk to them within 7 days of discharge. Why we are not doing this for every single discharge, I do not know. I don't know. We, the healthcare community, I mean, we could run it out of coverage just like we did 99358 if we build this to the extent it should be. Can you imagine? 99358, 99359, we loved that code. You get to review documents for hours on end, asynchronous, to prepare for a clinic visit. Medicare is not paying for those anymore because people caught it and they were like, this is amazing. Let's run this one out of business too. Let's bill it. Come on, guys. I want to hear like the success stories. Okay. Now, here's United Healthcare's time-based codes policy. It says for TCM in particular, you only get to bill this, one person gets to bill it, and only once per patient within 30 days of discharge. So you're going to report it, not bill it. So of course it has to be within 30 days. You have to see that patient within 7 or 14 days. Of course. Patient gets readmitted and gets discharged again. You can't just go crazy billing this code over and over for the same patient with the same healthcare provider. And you can't do it you can't initiate it that as that 993, like when you're billing 99238 or 99239 for discharge. You don't get to use that as within 2 days. No, it has to be after discharge. And then if you're the surgical person, you don't get to do this either, because you're transitioning their care out. Okay. So that's what I have to say about TCM. Run that code into the ground. I'm saying it's just low-hanging fruit in our troubled time of telehealth uncertainty. Okay, so it does have a little asynchronous, synchronous, fully billable, no matter where you are. Okay, now I'm going to move on. I'm moving on. General Behavioral Health Integration Care Management, GBHIC. JBIC. I have no good acronym to call this. I don't know what people call this. It's easy to do. Here's more low-hanging fruit. You do have to have a behavioral health, probably an F, an F leading diagnosis code. You have to have a diagnosis that's behavioral health in nature. The staff person doesn't need to be trained as a behavioral health person, because you're managing their stuff for them behind the scenes. There are required elements. Oh, not those elements. Sorry, just a little levity. Okay. There's an initial assessment or follow-up monitoring using applicable rating scales. We know what those are, PHQ-9, blah, blah, blah. Behavioral health care planning. There's a care plan. Coordinate treatment for that person and continuity of care. Like, you've got a clinical staff person that does not have to be a behavioral health trained person at all. Staff, not an LCSW, maybe an LCSW in training that needs clinic hours, perhaps. I would hope that would suffice for that clinic hours. Somebody needs to try that out and run it down. Okay. MD, NP, or PA must bill or supervise. So it's got to be a qualified healthcare provider. If the staff member is employed by a hospital, you split billing in hospitals, of course. It can be billed out on the UB. The MD is supervising. There's a treatment plan. And again, you don't have to be a behavioral health care practitioner to coordinate somebody's stuff for them. It's like you're the executive secretary or executive assistant for all of your patients. I like that. I like that idea. Okay, here's Aetna. Aetna. They sent out a March 2025 Office Link update that goes into collaborative care. I didn't find anything going in through Availity or the policies, but there is this Office Link update. They expect collaborative care and reimburse for it. They expect it. Do it. Just do it. Okay. I am segueing into collaborative care management. We're not talking about CCM. That's later. I'm going from easy to hard because it's behavioral health and I don't want to get too far out of sequence. Comparing general behavioral health integration. Okay, general BHI. Collaborative care management. Does the person have to be psychiatric in nature? I mean, is a psychiatric consultant needed? Part of COCM is there's a consultant available. And this is a nice comparison, if I do say so myself. So you've got a manager Uh, you need you need staff time. You do have to have a designated behavioral health care manager. There are definitions of what that is in the collaborative care management MLN matters and on the AIMS site. I have URLs for that probably in the next slide. Minimum time. Oh, look at that. At least 20 minutes for BHI. This one, oh my God, sky's the limit. So much time, over an hour. General supervision, general supervision. Of course, this is all asynchronous, and we all are general supervision coming up in the Medicare physician fee schedule can be virtual. Should it pass, I hope everybody like submitted supportive comments for that, because we're all waiting for that gift from CMS at this point. Where's the finalized MPFS for 2026? Okay, payments lower, but it's easier. It's higher because it's harder. All right, example, PCP managing anxiety, depression, or substance use disorder with check-ins. And then, of course, the comparison is like the full Monty of COCM. That's not appropriate either. Alert. So yes, what follows is out of my sequence. It's the hardest. Okay. These are the codes. I'm not going to read them to you. I've been reading a lot of stuff to you. I'm so sorry. But this is what you can do. Now, I can't talk about this. I've tried to explain people how to do this. I've pointed them in the right directions. I'd say the one thing about doing this as a program is that you need a registry. You need to keep track of your patients. It's required. You need a registry. Doing it on a spreadsheet, probably not so great. Maybe, I don't know, some kind of database. Oh, here, and this is another question I've gotten about these codes. They're like, oh, can I build both G2214 and 99492? No. They're like, well, if I got to the 70 minutes, that means it's more than 30. So we get to build two. No, it's between 30 and 70. Don't double bill. Don't do it. Okay. Okay, I did add in some pricing. All right, so here's what I push people towards. You go there. There's so many free resources on the University of Washington site, on the AIM site, and also the APA. The APA, I created a login. I was going to do a little training, tell you what it's like. I got distracted. I didn't do it, but there's free training. So look here. If you purchase a subscription to their registry, the caseload tracker, you know what this reminds me of? I used to work for a couple of attorneys as a secretary. That's what we were called back then, not assistants. I was a secretary and good at it. I worked for some patent lawyers, and we had a database for all the patents when they were going to come up for reapplication for re-upping with the US Patent Office. So this is kind of the same thing in my mind. You need to track what's going on with your whole caseload. You can't do that if everything's just all willy-nilly in the EMR, I guess. Okay, here are the commonalities. These are the elements, and these are the commonalities between all the codes, initial, subsequent, add-on. There has to be a manager, designated manager. That's their title on their virtual business card. It's 1230. There has to be a psychiatric consultant. This is one of those MD, PhD people. You know, they're hard to come by. And I think what this model is doing, um, it says reviews cases weekly with the BHCM, but when needed. Like if they're not needed, you don't have to bother them for that week. It's just making good use of a limited resource so we can drive them into the ground with overwork. It's a great idea. We're just trying to take, I guess, CMS, Medicare, me as a representative of presenting these codes, taking the burden off of referrals to psychiatric behavioral health providers so we can manage that within a principal primary care provider's office. There's a billing practitioner. You just oversee the team. Bills for the service. Now, what does that mean? If you're billing, you should know what's going on. Don't just put your e-stamp on there. Okay, structured care plan. All these chronic care management, these are like little contracts with your patients. Like, this is what we're going to do for you, and this is what you're going to do for us. And this is how we make it happen to manage your disease process. Why not? Rating scales, PHQ-9, GAD-7. And then you do have to track the time. I think the registry on the AIM registry does have where you can track the time and then it'll tally it for you on a monthly basis. Anyone who's ever logged into that, I'm so sorry if I'm fibbing. Okay. Who pays for it? Well, not just Aetna, not just UHC, but we do have on the APA website an updated chart of who pays for it in the Medicaid land, which I know many people that dial into these webinars are very, we're helping. We're the telehealth people. We want to reach rural. We want to reach underserved populations. And this is a very nice. Oh, Arizona, yay. Oh, Colorado. We got to do some advocacy work there, folks on the call, if you're from Colorado. Anyway, they have a very nice set of clinical examples on this video. So here's where you can find the codes, and then the EPA has this video. It's awesome. There's so many resources out there. Well, it's limited enough to not be so many. Okay. Arizona specific payers. I'm just tailoring this to, we're Southwest, we're TRC, I'm just being Arizona centric. I'm not being California centric today. So this is where you can find the coverage policies. Helpful, right? So Mercy Care, they cover it. Okay, I'm not going to talk about that anymore. That was a very high level discussion of these very complex little microcosm of managing. But if you actually get a behavioral health manager in your primary care office and you have a person that you regularly refer psychiatric patients to, why not say, hey, psych provider, let's do this. And maybe they'll share in the cost for the registry for you. I don't know. I'm thinking out of the box. We're all friends. Where are we? How can you combine virtual modalities and on-ground services? So think about it. What did we just talk about? TCM, GBHI, COCM. How would you do it? How would you work this into your clinic? TCM, I would do every single discharge. As long as it's not a discharge for someone that came in to have, I don't know, Well, even in elective procedures, high risk. If I were running all the healthcare systems in the world, I'd be okay. This is what we've covered so far. We're doing good on time. Okay, PCM. This is okay. As you can see on my list, this is next in my belief, because I've actually helped a provider implement it. Didn't bill it that much. Didn't bill it that much. We did implement it in my healthcare system. Um, it's not a big lift, you know. Uh, it's 30 minutes. It's one high risk condition. What high risk condition do you represent on this call? Do we have cancer providers, oncology, ophthalmology? Maybe someone's got glaucoma. You don't want them in the office all the time. Well, you have to measure their pressures, but you know what I'm saying. Something that's high risk. It's not necessarily chronic. It's principal care management. This is how the qualified healthcare provider bills. First 30 minutes per month, managing it. The requirements are over 3 months expected in duration. If you're going to bill 1 month, I don't know, some auditor might look at it and go, whoa, that's just one code. What are they doing? I'm going to look at the rest of their stuff, I guess. I mean, they expect it's over 3 months of management. And you're frequently adjusting things for the patient, but it's asynchronous. You don't have to see them. I mean, I don't mean that in a negative way. I just mean that in a positive, like there is no requirement for you to, okay, oncology is high touch, but you don't have to interact with them every, face to face. Probably you do, but you can manage this on days they're not in the office. These are things that are going on in the background. Um, Not a whole lot of QHPs are billing this, as you might expect. Again, check out that CMS data warehouse. I love it. Here is a PCM managing staff. Now, it's clinical staff under general supervision. And in a facility, this would be billed out on the UBO4. Here I have who bills, physician, NP. I mean, in a place of service for a non-facility type place, yeah, these are the people billing on the 1500. But OPPS, if you look at the OPPS fee schedule, these codes are on there and they do reimburse for facility staff. So as long as there's a care plan and there's no requirement that the QHP build their own code. They do the initiating visit, like for everything else, hand it over to their staff. Because you have to consent the patient. There has to be an initiating visit. There has to be a documented consent. Either, they sign it or you document it in the health record. Only one provider can bill this per patient per month. So if the patient is getting care in 3 different health systems and 3 different health systems are billing 99426, whoever gets that code in gets paid. The other 2 don't. So make sure you're really getting the full message from the patient about where they're seeking care. So no one's going to be billing this 3 times. I'm just saying, that's an example. But yeah, you got to document the time. You have to add up the time. You have to, the documentation will be like, during 5 minutes, call the pharmacy, talk to the pharmacist about why the prescription is not ready. 5 minutes, call the patient, left a detailed message for them about where to pick up their medicine. 5 minutes, ask the pharmacist to compare medications just to make sure there's no counterindications, things like that. And then add up the time. And it does have to meet the base of 30 minutes. These are not rule of half codes. These are equal to or over. All right, how should this be done? You need something. I used oncology. I guess with CHF or COPD, diabetes. Yeah, I mean, any acute condition your patient is experiencing would be ideal for this if they don't have two things going on. And it's going to last more than 3 months. CCM, as you'll see, um, will be two conditions expected to last 6 months to the end of days. So what makes this distinctive from CCM? Can't bill for the same condition in the same month. If you have different conditions, say you've got an oncology provider over here doing PCM, you have a PCP managing the CHF and COPD. Just make sure some, provider or coder doesn't add COPD onto the PCM code. It's oncology. General supervision, we love that. All the care. When's the next visit? Can I schedule your next visit? That took me 10 minutes while we looked at calendars. All that stuff is trackable and billable if you have staff willing to do it and providers. Not fun. None of this. I would think it was fun because I'm that kind of weirdo. Like, I think it's fun to transcribe or transpose French horn keys from the key of F into B flat basso. I mean, that's fun for me. For other people, not so much. Give me the transpose part. I don't want to do it in my head. Same thing. Like, you find that staff member or provider who is incentivized to take care of that patient population. Consent, frequency, once per calendar month. There is an FAQ I read somewhere. I think it was on the Coding Intel site where Betsy Nicoletti had documented that the date of service for any of these codes is either the end day of the calendar month or the date on which you stop coordinating care for that month. Like, if you get everything done today, I have to look what day it is. October 28th. It was my dad's birthday. Put October 28th on it because we're talking about calendar month. It's not rotating 30 days nonsense like for RPM. But you don't have to do from to like for ESRD or hemo, like it's not from to. It's not like you're covering all this stuff this date to this date. It's just the date you finish your time accumulation or your work for that patient for the month or the last day of the month, whichever is easier. Like if it triggers once you enter 60 minutes or whatever in your EMR or however you have your plan set up, your plan, your data management database that you purchase, and it can drop the code just for you like magic. I haven't come across where that happens anywhere. Hopefully the AIM program does. Okay, enough of that. I was talking about how much I love RPM and RTM and how hard it is to bill. I don't want to talk about it. I don't want to talk about it. I did do a presentation on this a couple of years ago. What? Only 4 views? Crushed. I was crushed. But you can download the PDF and listen to my dulcet tones and drive up the usage. There's 45 of us on this. If we all go to YouTube and watch it, it'll go up to 60 views or something, 58. Okay. Remember, we're going to get that MPFS soon. I hope. If there's anyone. There are people reading comments and they are going to address them and publish them. I have faith. There are new RPM codes that the AMA adopted, and we know CMS is going to adopt them as well. It's going to allow for 2 to 15 days of data. So we don't need to stick to that base of 16 days of data in order to bill. They're going to pay less. But hey, billing anything as opposed to nothing is what we're concerned about. So yay. Okay, go watch that. I just winked at you guys. Okay. So chronic care management. Down, down near the bottom of my list before COCM. I'm going to wrap this up really quick too. QHB, qualified health provider. It's the same as above. I put this, I resorted the slides. Who bills? An MD bills. Okay. Yeah, you're managing this. It's direct provider time. It's not the provider like talking to tell someone else to do something. It has to be your time. Now, if you, as a provider, you contribute something to what the staff is going to bill, that's okay. You can do that. And another question that someone brought up too, that I've been mulling over is, oh wait, it's not this code. It's the next one. 99490 has work RVUs ascribed to it. So if you're in a non-facility, you get paid for the practice expense and some work RVUs because you're supervising, right? You're paying for everything, so you get paid for it. In a facility, there's work RVUs. And there are also this code also, these two codes, it's out of sequence. 99490, 99439 is out of sequence. It's on OPPS. It can be billed on the UB04. If anyone has any ideas about billing both on the 1500 and the UB04, tell me if you've done it or not. It's bugging me. They're like, oh yeah, there's work RVUs. It'll be paid less because this place of service 19 or 22. And then on the UB04, you get paid for the staff time because the facility hires the staff, not the providers. Anyway, perplexing. It's all the same stuff. You got to track everything. You got to consent. Everything's under general supervision. 2 or more chronic conditions. Where is my lip today? Risk of death or decompensation. Distinct. Again, same as I said above for PCM. General supervision, MPFS, let the supervision be general via telehealth, no matter where the patient and clinic is located. Care plan. How you gonna do it? Got your consent once per month. Bill it like I said. Only one provider. Record total minutes. Got your care plan activities, coordination notes. I think a macro that says I did blah, 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 blah. And that shows up on every patient chart. If I were an auditor, I guess it would pass, but I don't like it personally because it's not specific enough to each patient. Okay. Care plan. I've seen macros. I've seen them. I'm not excited about them. Change them a little. Okay, care plan must be available electronically. So if you have an electronic EMR, which we all have to now because it was mandated, 20 years ago, time thresholds. Everything is like, there's no rule of half. Complex. I did mention it's the same thing, except there's more going on. It's moderate to high risk associated with a particular patient's condition. Now, they might go out of CCM and complex CCM month to month. This is what's happening now. So moderate or high complexity. So say the patient is, I have examples. I don't listen to me. I'll just make stuff up. I've never built this. I've only audited. Everything. These are no rule of half. Forget it. This is 90 minutes if you want to build both of these codes. The little plus sign means that's an add-on code. Okay, I'm pointing at my screen like you can see me. So complex versus basic or mix and match, what fits your patient population? Do you anticipate using complex? Then you must have like the ability to bill for that in your CDM, your charge description master, and what's available. Have you priced it? Have you negotiated with private payers? It's all general. I mean, pretty similar, pays more because your patient's sicker. Who performs? Complex, less intensive, like medication, routine. One provide, it's kind of the same, pays a handful of dollars more, 30 to $5 more. Okay, here's an example. It's 1252. Mr. Lopez has type 2 diabetes and hypertension. It's not PCM. He's got two chronic conditions. So forget about those PCM codes. We're talking chronic care or complex. Summary, they're well controlled. Does not sound moderate to high to me, but let's go on. The care team, they're doing monthly phone outreach. Hey, your glucose looked bad. What did you eat yesterday? Hey, your blood pressure looks great. Maybe you want to do RPM to enhance your CCM. They can be billed for the same patient in the same condition in the same month. Think about it. Just think about it. RN updates the electronic care plan, coordinates with the PCB. Oh, I'd be having an overdue eye exam. No medication changes. Now, it mentions medication, and you know in the 2021 E&M guidelines, medication means moderate to high risk. We're not changing it. There's no moderate to high risk with this. So yeah, it's 25 minutes of staff time. Care plan was reviewed. We got the verbal consent. What are we billing? This. Is this telehealth? No. Place of service 11, 19 or 22, or all those other ones I had on those slides. It's not 02 or 10. It just isn't. Okay, I've got one more. Uh-oh. Ms. Thompson is not doing great. She's got a lot of stuff going on. CHF, COPD, CKD, stage 3. 2 medication adjustments, moderate to high risk. RN and pharmacist conducted multiple follow-ups. She's not doing great. Care team coordinated among cardiology, nephrology, and pulmonology. Updating everybody. Hey, maybe you want to pull her in for a visit. You know, because you're coordinating all of these conditions with specialists. Maybe you sent them an e-consult and got a message back and implement and use that for your care plan. Think about how you can use e-consult within your own health system to coordinate with specialists without having to send your patients there. Be great if it was their specialist. That care plan required weekly updates. Her weight was up and down, renal function declined. There were some labs. The physician had to review everything, sign off on the RX, all that good stuff, authorize changes. Yeah, this was complex. There was a lot of time spent, and it was moderate to high complexity. And I've left you a whole 5 minutes to ask questions if you have them. And I also have all the resources, most of the resources for you. So there we have it. Does anyone have any questions? We have questions in the chat.
We did have one question. Someone was asking the difference between CCM and PCM. CCM is, I believe, chronic care management, and your PCM would be that principal care management. Is there any other difference between the two?
Right. So in the chart earlier, let's go back to that. I'm proud of these charts, man. I'm just telling you, these were labors of love. I'm like, I'm gonna do right by these people. Let's see. Did I compare them? Yeah, sort of. Let's see. So what happened? So, okay, I didn't compare them. Okay, distinct from CCM. PCM is one condition, CCM is two or more.
Or more.
Yeah.
Yeah.
Don't
That's the biggest difference. Yeah.
Yeah, don't pick two and say I'm done. If you're managing three, list them out, manage all three.
Right.
If they have five, you're going to be complexing all over the place. Anyone else?
Oh, do you know where you can find information, where they can find information on how to bill audio only visits, especially for United Healthcare Advantage plans?
Yes, and this is the magic of the Google. And I'm not proposing, you can go to ChatGPT, ask it. Search audio only services UHC. Now, for RPM, I know you were talking about audio only. You know what? They have to cover it if Medicare covers it. So at least they have to cover it for any region, rural or not. So what you'll find is the policy on telehealth services and audio only will be in there. Sometimes they're limiting it to the schedules that you can find or the appendices you find in the AMA CPT book. My friend told me she just got her professional edition the other day and she was so excited. I haven't bought a new CPT book in years. I subscribe to something online. But the books are nice, but there's a lot of paper chaff. But I digress. They have to cover what Medicare covers, and they sometimes say limited to what the AMA thinks is audio only.
Are there specific CPT codes for the
Yes.
audio only visit? Yes, there are. Okay.
Yes, what they consider to be acceptable. Now for RPM, what I was going to mention that I was surprised, another client asked, oh, can you tell me why this client of ours said UHC doesn't cover all the Medicare conditions for RPM? You go to look at their policy, it's limited to CHF and hypertension in pregnancy only for the commercial plan. I thought that was surprising. So I included it on the resources because I thought that was something interesting. Because, why not go down that rabbit hole? Any other questions?
It doesn't look like we've got any other questions right now, but yes, everybody, the slides will be available in the handout link. And I will, again, will send that in my thank you email to everybody. Hold on just a second.
Yeah, and thank you everyone for your attention and for I hope you learned something, and I would love to hear back if anyone implements any of this. Contact us. It would make my heart proud of you, and it would just be great to get some feedback on whether or not you're going to build TCM. Anyway.
So again, Carol, thank you so much for joining us today. And just to let everyone know, we are going to, we're in the process of putting together another webinar and bringing Carol back in December. We're looking at that date. We'll get some information out. And I think we're going to do it more like an office hours. So bring your questions, and hopefully we might have some headway with the government shutdown and what that has done to various telehealth billings and whatnot. And she'll be able to take a deep dive into that and share the information. So again, watch for our upcoming events. And if you haven't subscribed to our newsletter and event newsletter, please go ahead and do so. I'll have that in the thank you email in case you need the link for that. And again, thank you everyone for joining us, and we look forward to seeing you again. Take care, everyone.